Welcome everyone to the next session with Dr. Manjunath. Over to you, Doctor.
Thank you. A very warm greetings to everyone there. So this is Dr. Manjunath Dosheti. I am a nephrologist based at Chirai Hospital, Kalburgi. Kalburgi is one of the important districts in northern Karnataka. Myself, being a nephrologist, I am also doing AV fistula surgeries for the past many years, having done over about 800 surgeries. And I'm glad to share my knowledge about how do we preserve AV fistula access in the long run. So we are going to talk about what is the science for making long-standing AV fistula. So at the outset, I thank the Kidney Warrior Foundation for having given me an opportunity to talk about this topic. And this is dedicated to all my patients from whom my learning continues to improve. And thank you, each one of you, for joining this conference, which is aimed at improving the life of dialysis patients across the nation. So today's talk would be divided into these headings. What is the need for AV fistula? What is AV fistula? That is arteriovenous fistula. When do we get it placed? Where to get it placed? And how do we achieve long-term survival? And how do we recognize that our fistula is getting harmed? So as you all know that in our body, peripheral veins are small with low blood flow. Neck veins, although they are larger, they are not suitable for pricking. But what do we require for dialysis? What we require is that the veins need to be superficial. They need to be large with high blood flows, and they should last longer, least chances of infection, and they should be relatively cheaper. Hence the need for AV fistula, which satisfied all these criteria. So what is the arteriovenous fistula basically? So many patients have a misconception that some machine is put inside because it makes a sound, there is a thrill, but there is nothing artificial inside. Basically, the natural superficial vein is joined to an artery where the arteries are deep-seated with high blood flows, and this is what we call as an arteriovenous fistula. So the high blood flow from the artery will enter the vein, and over weeks the vein becomes large in size with high blood flow. Then the vein is superficial and easy to cannulate. So when should one get an AVF placed? So ideally, it should be preemptive. What do you mean by preemptive means? We should get it placed before the need for dialysis arises, or at least as soon as possible after starting dialysis. The longer is the delay between starting dialysis and getting a fistula placed, the tougher it becomes to create a AV fistula. Then when do we start using the AV fistula? If we should not harm it, then ideally 6 weeks after surgery, not before 3 weeks. But sometimes many patients have catheter-related issues, so we can start using the AV fistula after 3 weeks. So where do we get the AV fistula placed? Where should be the location of AV fistula? So it should be the non-dominant upper limb, that is usually the left. If you're a right-handed person, then you will get the AVF created in the left upper limb. Then within the limb, where do we do it? Whether we do it at the wrist or in the arm, that is above the elbow. So ideally, we prefer it in the wrist than the elbow. The reason is that we need to preserve the elbow veins for future access. Now, when it comes to as far as good flows, if you want very good flows of the fistula, we want the fistula to last longer, then what matters is the adequate size of the vein in the artery and not the location. So if the size of the vein and artery is adequate in the wrist itself, then a wrist fistula is good enough. So although the arm has a larger vein and larger artery, many people have a misconception that the arm, that is, I mean above the elbow, that it will be better. No, exactly not. If the forearm artery vein and artery size are adequate, then forearm fistula is as good as a arm fistula, that is the elbow fistula. People who are elderly, there we have a general tendency to opt for fistulas above the elbow, because there usually at the wrist the arteries become hard and the veins are also not that suitable. So in older people, we tend to prefer fistulas above the elbow. Then how do we achieve long-term survival of the AV fistula? Of course, these are cannulation techniques, which are all purely technician and the nursing staff driven. Usual sterile precautions. What we need to remember is a newly created AV fistula should be cannulated by some senior staff. What do you mean by cannulation is pricking the AV fistula. Then proper decannulation. Tourniquet should not be kept for more than 4 hours. Then we have what is called as buttonhole cannulation. Buttonhole cannulation means we prick the fistula at the same spot every time. In stepladder cannulation, we keep rotating the prick site. Stepladder is opted where there is a standalone dialysis center where nephrologist doesn't visit regularly. So there we need to have a stepladder cannulation. Then how do we achieve long-term survival of the AV fistula? The patient should avoid sleeping over the limb, avoid scratching, avoid heavy weight lifting, especially after surgery. Avoid wearing a wristwatch, jewelry, clothing with having tight sleeves. So these things are the ones we should avoid. And not only that, we also need to care the other limb which doesn't have the fistula. We should avoid frequent pricks to the other limb. Why? Because in case future any access is required. So what is the trick here is that whenever any blood tests are ordered by the doctor, try to get the test done during dialysis where they prick the AV fistula. From there, they can draw the blood. Unless and until there is an emergency, you get your test done during dialysis. Then how do we achieve the long-term survival of the AV fistula? Is also about the medications. Aspirin 75 to 150 milligram. If a person is diabetic, then he should mandatorily take aspirin. Avoid taking BP medicines on the day of dialysis. Your BP medicine should be regularly modified. Be in touch with the nephrologist or the dialysis medical officer. Many times it happens that as the time passes on by dialysis, your blood pressure tends to normalize, and you continue to take blood pressure medicines which were prescribed about 2 or 3 months back, and then your blood pressure goes down, and then your fistula will fail. So fistula failure, one of the causes is low blood pressure. So see to it that you get your blood pressure medicines modified regularly with your nephrologist or the dialysis medical office. Then how do we recognize a failing AV fistula? We look for thrill at the vein on non-dialysis days or any new development of swelling in the fistula limb. It is a sign that your vein, there is a venous stenosis. Stenosis means there is a narrowing of the vein. Any reduction in flows during dialysis, any increased venous pressure alarms. You might have come across those who are getting dialyzed regularly. There is a thing called as many alarms are there in the machine. Sometimes the machine will give a venous pressure alarms. It means that the vein has probably narrowed up above, and that is also a sign that the fistula may likely fail in the coming future. Then any symptoms of loss of appetite. You are not feeling well. You are going for regular dialysis. You are going for frequent dialysis, but still your appetite is not improved. Still you are having vomiting. It means probably your fistula flow is not good and that you are not getting dialyzed properly. So that is also any symptom of loss of appetite is also a sign that your fistula is not functioning properly. Then there is something like is more technical, that is urea reduction ratio. This is a test which is done in the dialysis. We measure your urea before dialysis and after dialysis, and we see to it that whether adequate clearance of the waste products is happening or not. If it is inadequate, then it is also a sign that probably your fistula flows are not good. Now you can see that this is a both the two limbs. I have put it in comparison where the fistula band is there. There you can see the swelling. That this happens when your upstream the veins are narrowed and you can get a swelling of the fistula hand. And in such case, down the line, the flows may become reduced and your fistula may fail. So to summarize, AV fistula is the best access among all the accesses. Timing of placement, it's better to get a AV fistula created before we start the dialysis. AVF location does not matter as far as size of artery and vein is adequate. Forearm is better to preserve veins for future access. Forearm means at the wrist. Then monitor the thrill of AVF regularly when you are at home. Thrill means the vibrations which you feel on the fistula. Then loss of appetite or vomiting despite frequent dialysis could be a sign of failing AV fistula. Report to doctor in case of new swelling in the limb or if there is a difficult cannulation, difficult pricking, low flows during dialysis, or if there are any venous pressure alarms. Please do report to a nephrologist once a month for titration of medicines. That's all for. Thank you once again.
Thank you so much, Doctor, for this wonderful, and we got such a learning from this presentation. all the kidney warriors are so grateful to you for presenting this. I thank you on behalf of Kidney Warriors Foundation and hope you keep associating with such wonderful presentations.
Thank you. Thank you. Welcome.
We are now over to the next session. Thanks.